It's a great pleasure to be here, and I'd like to just first of all tell you where I work and live at present. You can see on the slide here, this is Sheffield. It's the Don River Valley where steel production was born in the modern age, the Industrial Revolution, and this is the basically where I work in the building at this sort of level at the hospital. Sheffield's in the centre of the UK, and I hope if any of you are coming to the UK, you'll come and visit us. It's got beautiful countryside, and you can see one of the great redeeming features of an industrial city such as this is the fact that we actually live with this countryside roundabout. And you basically can see the hospital in the distance there, and this is the countryside where we live, which is a couple of miles from the city centre. And there's another view just to show you. As a functional urologist, I often feel a little bit like this when dealing with oncology, which is clearly so much more important in terms of life-saving and so on. But I would say to you that we mustn't forget functional reconstruction and the importance of this in all of our lives as we get older, when we're affected by disorders affecting the bladder itself. I'm going to be talking about pharmacology, and I thought it was entirely appropriate just to mention that working in the area I do, I've got a doctorate in pharmacology as well as my interest in surgery, and I have worked as a consultant researcher with a number of the pharmaceutical organisations. I'm going to talk a little bit about the innervation of the urinary tract, particularly giving you an overview of the central nervous system and the importance of the peripheral mechanisms, with an emphasis on what we understand in 2009 about the control mechanisms for the bladder, overturning a lot of the conventional views that we've held in the past. I'm going to also just provide the update on the International Consultational Incontinence Committee on Drug Therapy for disorders of the bladder, which I co-chair with Carl Eric Anderson. That's from the meeting last June. We're all familiar with the standard innervation of the urinary tract, the somatic nerves via the pudendal to the outlet from the bladder, the parasympathetics producing the main motor control of the bladder, and the sympathetic nervous system relaxing the outlet and contracting the outlet and relaxing the bladder. If you actually look at the innervation of the bladder, one's got to think in terms of survival of the individual, survival of the species, as the underpinning phenomenon which underpins the whole central nervous system control of the body. And if you look at this slide from Holstake, who's one of the leaders in the field, this is a fairly old slide now, you can see that one's got to think in terms of the motor system of being somatic or the emotional motor system. And within that, of course, the bladder is not important for survival, but clearly very important in terms of the normal functioning of the bladder. The first thing is to consider the local reflexes for the bladder, and you've heard a lot about this in the recent past with the development of drug duloxetine for stress incontinence, which failed to be very successful, but which is acting at the level of onus nucleus, the motor component at the sacral spinal cord. And of course you've got the feedback, the afferent feedback, which we have totally ignored until the last decade. We've looked at the motor control completely at the exclusion of the afferent system. And in 2009 now we recognise that the afferent system is probably much more important in terms of functional disorders than the efferent system. You've got then projections to the centre, up the periaqueductal grey matter, which then comes down to the pontine Micturition centre, which is responsible for contraction of the bladder. And that completes the loop, if you like. And there are also interneurones, which are controlled by gamma-aminobutyric acid, which is also a potential pharmacological target. At the centre, there's been a lot of work done in the recent past, but it's very difficult to study the human, as you know, and most of the work's based on extrapolation from animals. But this is the most updated diagram that exists from Claire Fowler, Chet de Groot in Pittsburgh, and Derry Griffiths, you all know, and this just demonstrates that you've got these central mechanisms which feed back down via the periaqueductal grey matter to the pontine Micturition centre. And so you've got this loop completed. Now, if you actually look at the way it's thought to actually have these afferent impulses coming back up to the brain, and when these reach the centre, they are processed through the periaqueductal grey matter and go to these various nuclei which have been identified in the recent past. Then, of course, impulses come from those, and on the whole, the impulses are fairly negative in terms of control, and when those are released, then, of course, the pontine Micturition centre can act, and you end up with a situation with a positive response, allowing the brain to send impulses down to have an effect on the bladder to empty it. At the end of the day, that's normality. What actually is happening at the centre? Well, there's been a lot of interest in the recent past using modern imaging techniques, functional MRI and so on, looking at the response of the brain in the normal person without a functional disorder of the bladder to filling. And you can see here that certain areas light up, as shown by Derek Griffiths and his collaborators. And if you're looking at patients with urgency incontinence, note the new term urgency incontinence, I'll come back to that, which replaces the old term urgent incontinence. It's maybe a pedantic point, but important in understanding this area. So these patients have so-called overactive bladder, and you can see that certain areas, just making the comparison, light up a great deal more in these patients. And it was very interesting because this has also allowed them to look at slices across the brain in a sagittal direction, and you can see that on the left-hand side, normal controls, on the right, patients with urgency incontinence, and quite a different pattern. And this is clear evidence suggesting that the central nervous system is potentially very important in this condition. It's not just the peripheral component which people have focused on in the past. And currently all drug therapy is directed peripherally because of the central nervous side effects if you actually use agents which affect the CNS, as you know. And you can see that there was clearly effects in the central nervous system that Derek showed. Coming now to the periphery, we're all familiar with the detrusor. The name, in fact, also emphasizes the emphasis we as urologists have had in the past, and urogynecologists, on the detrusor as a functional organ causing contraction, because the term comes from the Latin detridare, to drive out, to drive the urine out. So as urologists, we've really focused in the past on the function of the bladder, the contraction of the bladder, and everything has emphasized this. But of course, as I've mentioned, we have these afferent or sensory mechanisms, we have the peripheral and central motor mechanisms, and we mustn't forget, as we see as clinicians, that particularly after sling surgery, you can get urgency and urgency incontinence developing, which is probably due to afferent stimulation at the level of the urethra. Okay, is that fanciful? Well, it's real, isn't it? These patients are very upset if they have this complication. If you go back to about 1982, Chalfin and Bradley reported in the Journal of Urology, if you inject lidocaine into the prostate, doing urodynamics at the same time, you can demonstrate that detrusor overactivity is abolished for the duration of the injection of that lidocaine into the prostate. More recently, you've come across preliminary reports of using botulinum toxin into the prostate, affecting bladder behavior. And again, that's more emphasis for the afferent system. But the conventional wisdom was very much that we all know that men with prostatic outlet obstruction get developed detrusor overactivity in at least 3/4 of cases. And 2/3 of those patients have complete relief of the overactivity and the storage symptoms if you carry out a prostatectomy. It's clear, isn't it? Relief of obstruction relieves overactivity. Or does it? This has led on to all of these models obstructing small furry mammals and producing abnormal bladder behavior, patting ourselves on the back and saying, well, there's a model for detrusor overactivity. Now, detrusor overactivity, which underpins the storage symptoms of overactive bladder, is a definition. It's a rise in pressure in the bladder in a conscious, cooperative person who is trying to inhibit voiding, and you emphasize that to the patient. If you have an animal with involuntary detrusor activity due to acute obstruction, usually in a female animal, a juvenile, where there's growth that's occurred leading to this acute obstruction, is that detrusor overactivity? Of course it isn't. Alison Brading and her group in Oxford came up with this hypothesis and this model, and it's been widely adopted in literature. But I would suggest to you, as I hope to emphasize to you, I think it was barking up the wrong tree. But certainly this emphasis does exist in literature, a denervation supersensitivity following Cannon's law, leading on to detrusor overactivity, and also affecting bladder behavior by an effect on the muscle directly. Now, if you actually look at what are the potential mediators in the detrusor, noradrenaline, which we've poo-pooed in the past, as I said at the start, the sympathetic causes relaxation of the bladder, contraction of the outlet, and people say, okay, so what? A little bit about that in a moment. And there are a number of other agents, all of which are being focused on in terms of pharmacological research at present. If you look at the sympathetic nervous system, there are beta-3 adrenoceptors on the bladder, and if you actually stimulate this, this will inhibit adenylyl cyclase, leading to an increase in ATP. And of course we've seen the positive effect of the phosphodiesterase inhibitors in erectile function, so why shouldn't AMP augmentation in the bladder relax the bladder? Is there evidence for this? Well, there was basic science evidence until recently, but at the European Association meeting this last year, 2008, I was able to report the first data from the use of a beta-3 agonist showing results which were very similar to one of the most commonly used anticholinergics. It's not powered to look at a difference between agents. As you can see, it's a small phase 2 study, but there are phase 3 studies which will be reported in due course. And you can see that. So why should we consider the use of antimuscarinics? Well, we do know if you take muscle strips, you can inhibit most of the contraction of the bladder by the use of the cholinergic antagonist atropine. And certainly if you look at the animal models which have been reported from Japanese co-workers and others in the States, where they produced models which were where there weren't any muscarinic receptors, you can show very clearly that mice lacking muscarinic receptors have severely impaired detrusor contraction as compared to the wild type that you can see shown in blue. We do know that even though the majority of receptors in the bladder are the M2 receptors, that's 80%, the M3 receptors, as shown by work from a number of labs, including ours, were the most important. And certainly you have complex diagrams of this which don't actually have much interest for us as clinicians unless you're working in the area, because they don't actually help us in understanding the situation, rather just to say that an antimuscarinic inhibits bladder contraction. And here the emphasis, you can see, is on the motor side in the past. That's what we all know, that's what's conventional wisdom. But is it how these agents work? That's the question. Certainly they work elsewhere, causing antimuscarinic side effects. We know that, effects on the brain, the heart, the gut, and so on. But certainly now if you look at ongoing work, this is some work from our group, from Stevens, you can see that there is a change in receptors activity with detrusor overactivity. And we also know that if you look at the detrusor from patients with bladder overactivity, detrusor overactivity, there's a higher non-cholinergic component, which you can see at the bottom there, isn't abolished by atropine, but is abolished by the ATP inhibitor, for instance, alpha-beta-methylene ATP. And it's certainly now been shown in the literature that a number of patients with functional disorders, both neurogenic, related to obstruction, idiopathic overactivity, and aging, as well as sensory bladder disorders, may have alteration in the innervation of the bladder. For instance, Yoshida from Kumamoto in Japan has clearly shown that there is an alteration, as you can see here, in the sensitivity to atropine as you go through different age groups from 50 to up to around over 70, and this is in part explained by, for instance, an increased purinergic innervation of the bladder. Okay, so this is hypothetical. How does it actually relate? Well, there's others that suggest that this is not a real finding, and this is work from Dresden in Europe. We're really finding our way. We're learners in this area. As we know, in the field of oncology as well as in pharmacology, we have so much to learn. We just have pointers, and at the end of the day, we need to move forward. So where do we stand in terms of our functional understanding? This is work based largely on Chet de Groot and Carl Erik Anderson's contribution to the literature. But certainly we know with bladder distension, the normal patient who hasn't got overactive bladder symptoms or frequency due to other causes other than detrusor overactivity, that there is a normal situation that bladder distension activates the center, producing the normal urge to void. The urge is normality. If you look at a patient, therefore, with this, you can control it until you find a toilet, finish what you're doing, and empty the bladder. If you have overactive bladder, which is a storage condition, then you have a very different situation, where you have an alteration centrally, as shown by Derek Griffiths, leading on to an abnormal pathological symptom of urgency. And now English is the only language where there's clear distinction between urge and urgency. And in the past we've tended to use the terms interchangeably. But now within the functional urology and urogyny community, we recognize it as a term relating to a pathological symptom. And of course, this in many patients leads to reflex voiding and leads to urgency incontinence. What are the potential mechanisms? Well, there may be alteration in bladder behavior. There may be afferent changes in the reflexes. You see this, for instance, potential for this with multiple sclerosis. and other conditions affecting the nerves, and the same applies to the spinal cord. And also there may be alteration based on the center with aging, the central control mechanisms which lead to enhanced reflex activation. The next misnomer is the bladder as being having a urothelium which is just a barrier. Now we, as urologists, we burn this away with tumours, we take little note of it, except in painful bladder syndrome, with these unfortunate patients we feel have an abnormality of the lining of the bladder barrier. But we forget that the urothelium has a metabolic rate 3 times that of the detrusor muscle. We also don't altogether take account, or haven't explained in the past, why the urothelium has a receptor density twice that of the muscle. Now, of course, receptor density doesn't relate to function. That's very clear from pharmacological work, but clearly these receptors must have a role. We now know that bladder distension, of course, activates sensory neurons, but there is also non-neuronal release of neurotransmitters, which has been shown over the last several years, very clearly by all the labs working in this area. So as you stretch the bladder, we don't have stretch receptors in the human, unlike the cat, we have Pachydian corpuscles. And in the past we've used in the textbooks, it says, well, there's stretch receptors on the peritoneum. That's slightly balmy, isn't it? Because the peritoneum only covers the dome of the bladder. If you want to actually design a mechanism that works, then you've got a bladder, as it fills up, you start getting a stretch occurring which leads to an increased release of neurotransmitter, and that can of course trigger the nerves, as well as the nerves firing off when their threshold is reached. What's an example of that? Talking about this release of neurotransmitter. Well, clot retention is an obvious example. You know, clot retention, you get some clot in the bladder, we call it retention, but very rarely are they in retention, but there's intense spasm and discomfort, isn't there? You wash out that blood and that goes away. Oxyhemoglobin is the best nitric oxide scavenger known to man, and nitric oxide is a bladder relaxation agent. You can't use that clinically because donors are toxic. And of course, if you activate the sensory neurons, you also get a feedback loop, so you've got release of chemical neurotransmitter, and this is antidromic stimulation is also important in this, as we know, with the flare and wheel reaction from basic physiology. If you look at the afferent nerves, they're difficult to quantify, because if you actually look under the high power microscope, there's only a few fibers containing these putative neuropeptide neurotransmitters in the suburothelial plexus, and it's difficult to quantify them, but clearly they are important, and you can show muscarinic receptors related to these on the urothelium. The next part of the jigsaw that's become clear in the recent past is that, okay, this is all very well, chemical neurotransmitters going on to sensory nerves going back to the spinal cord. And we do know that these neurotransmitters are definitely there, they're being characterized and quantified, but we've now realized that there are cells called myofibroblasts, or the interstitial cells in the bladder. These were discovered 100 years ago in the gut by Hallam, and clearly, as you recognize, there are so many similarities between the way the gut, the lower gut, and the bladder work that it's not surprising that you've got a similar mechanism. They live in Auerbach's plexus and so on in the gut, and now if you actually look at them, they're c-KIT positive, these cells. You can find them throughout the bladder, in the urothelium, the suburothelial plexus, and between the detrusor muscle fibers. Isn't it amazing? They were only really recognized about 10 years ago. If you actually look at these, they have close apposition with the nerve fibers. And so you've got a situation, if you look at the detrusor muscle, that you have these interstitial cells forming a syncytium through the detrusor muscle. You can show muscarinic receptors on these, combined with the c-KIT, which is a marker for them. And indeed, something of interest to you is that you've come across Glivec, which is introduced for hematology in the recent past. The c-KIT, it inhibits c-KIT, it's a very potent drug. It also, in muscle strip experiments, stops the bladder strips contracting. Interesting, isn't it? The analogy with other fields. And you can show these muscarinic receptors clearly on EM, on interstitial cells. You can isolate the interstitial cells, and you can show that they respond to cholinergic contraction. This is work from McCloskey in Belfast, in Northern Ireland. And you can show this very clearly. It's mediated by muscarinic receptors. So the next part of the jigsaw now is you have a system where the bladder, as it distends, releases the neurotransmitter by firing nerves, as well as direct non-neuronal release. And you've got a complex mechanism which allows delicate control, which, if the brain is working, normally you've got a threshold which you can control, you don't fire off. And then the whole thing feeds back like that, and of course you've got the syncytium between the smooth muscle cells, and you've got muscarinic receptors which are involved. So, you can see there is clear reason now to believe that agents working on muscarinic receptors don't have to just work on the detrusor muscle, and that's why no studies of antimuscarinics at clinical doses have shown changes in contraction of the bladder on urodynamics, and why it's very rare for patients to go in retention unless they have a poorly functioning detrusor. I'm not saying you don't give a high dose of atropine, you'll put anybody into retention. Of course you will, but that's super threshold. Now, how could we actually progress this? If you take afferent mechanisms such as this, preparation of the mouse or rat bladder in this case, you can show that low dose of tolterodine, an antimuscarinic, should have an inhibitory effect on C-fiber bladder afferents. And you can show that before and after racinophrotoxin, which damages the sensory nerves, where you've inhibited the effect of an antimuscarinic. And you can show, certainly from another study from Carl-Erik Adamson's lab, that there was an effect which wasn't as pronounced. You can see in yellow there after racinophrotoxin. Darifenicin, another antimuscarinic, and I'm using these names interchangeably because all the antimuscarinics act by the similar pharmacological mechanism. Darifenicin also has been shown similarly to have an effect on the afferent nerves. Now, there are pharmacological differences between these agents pharmacologically, but the receptor profile is not particularly significant, I think, in clinical practice, although at marketing they tend to say otherwise. If you look at function of the bladder, then you have a situation where you also have work which has shown that the bladder acts as a functional syncytium. And this is from guinea pig bladder work, and you have the bladder with waves of contraction passing across it. And these waves of contraction can be quantified. They've done it in Pittsburgh, they've done it in the UK, Drake and Gillespie, and it's thought that you have therefore a bladder which is doing this all the time as it's filling up, and why on ambulatory urodynamics we get a very high level of involuntary detrusor activity in the bladder, and when this reaches threshold, then the bladder fires off. So basically you can see that the efferent system is just part of the system. The afferent system is clearly very important. You've got a situation, therefore, where there are phasic muscle contractions in the bladder which are part of normality. You've got the afferent effect of urine going into the proximal urethra, which may be important. You've got the importance of activation of sensory nerve fibers, and this is a target, certainly, for the future, with a number of agents being developed in this area. And, of course, you've got the center, which we don't want to target pharmacologically because of the side effects, and we don't really know what we're doing in that area. But also at that level, in the spinal cord, you have the potential for neuromodulation, which I'll come on to briefly, which of course is now of great interest and very popular. So this is an appalling diagram, but it's really just summarizes what I've said. You've got the urothelium with these neurotransmitters which can be released by stretch in a non-neuronal fashion. You have these interstitial cells which exist throughout, which act as a neural syncytium. You have the afferent nerves, and I would just emphasize here for the vanilloid receptors, which are a target for agents such as racinophrotoxin and capsaicin, which are neurotoxic, and which actually affect the bladder significantly. And you've got the efferent nerves, the mechanisms you're familiar with, which can be affected by both antimuscarinics and the beta-3 agonists. So I hope that's clear. At the end of the day, in 7 years' time, probably 80% of what I said will have changed in terms of the pharmacology, as in so many different areas. But I think the emphasis hasn't changed. If you take the vanilloid agents, these are all related to hot peppers, capsaicin, and the more potent one, racinophrotoxin. When I went on holiday with my family to Africa this year, I realized from what they had explained to me that a big tree, euphorbia, is a source for racinophrotoxin as well. And the bushmen used to take the sap and put it in the water, and the fish would all float to the surface. So that was the basis for their poison. So racinophrotoxin and capsaicin have both been used. If they put it in the bladder, they actually can cause retention for up to 6 months or longer. And that's not acting on the motor system, but the afferent system, working at this level by damaging the sensory nerves. We mustn't forget Botox, which is all the rage at the moment, based on the work of Bridget Schurch in Switzerland. Now everybody's using it. It acts in skeletal muscle, blocking the snare protein, SNAP25 and so on, But that's skeletal muscle, the cholinergic system. There's now good work coming out of Apostolides and Fowler showing very clearly that this is actually probably working on the sensory nerves as well in the bladder, and that's why if you use it in patients, you only put a proportion of idiopathic overactive patients into retention, less than 10%, 10 to 15%. It's different in neurological patients where up to 80 to 90% go into retention because they have disordered mechanisms. So there's a lot of work being carried out in that area, and there's a lot of interest for sphincter dyssynergia or the Fowler syndrome, where there's an altered innervation of the urethral sphincter, the overactive bladder, painful bladder syndrome, where there's very little evidence at present, and prostate, where there is no evidence which has come out of randomized control trials. In fact, none of this is licensed, as you know, at the present. Botulinum toxin says used off-label, and it should be used very carefully with careful consent of the patients. It is a toxic agent, and if it's used unadvisedly, it can be dangerous. Certainly, Bridget Church produced the very interesting evidence for this from her work, and that's ongoing. Neuromodulation we're all familiar with, based on the principles of acupuncture, S3 dermatome, stimulation thereof, the TENS technique, which was looked at by Stoller in San Francisco a number of years ago. But this is a very tedious technique because you have to continue putting in the needles and stimulating the tibial nerve. So it's not really reached a lot of people, not been of great interest to a number. Sacral root stimulation, based on the landmark work coming out of San Francisco, Tanago and his co-workers, but developed in Europe largely, and emphasized there before, was adopted by the FDA and licensed in the States. The Tyne lead, which is major breakthrough, coming from Spinelli in Italy, which allowed you to put in these electrodes easily, percutaneously. Previously, you had to fix these electrodes to the periosteum on the sacrum. At the end of the day, it's an interesting technique. It's good data coming out of randomized controlled trials in terms of improvement in functional and also symptom-related parameters. But don't forget, there's still a number of patients left with overactivity, and even if you have a positive percutaneous nerve evaluation and an implant, probably only 50% of these patients long-term respond, and the cost of this in my country is around £12,000 for an implant, and there's a maintenance of following these patients up. So it is a technique which is certainly valuable, but it's one not without its costs. Antimuscarinics clearly are potentially important, therefore, and we look at the micturition cycle like this, and we mustn't forget that over 98-99% of the bladder's time is spent filling, even if men have voiding difficulty. LUT Tract symptoms have been emphasized in the recent past. The term was first applied to the prostate and BPH by Paul Abrams to replace the term prostatism, and that belies the title of this lecture, which is basically that symptoms of the urinary tract don't relate to the underlying pathological or functional abnormality. The bladder is an unreliable witness, as my major mentor, Richard Turner Warwick, said many years ago, because symptoms aren't disease-specific. Patients have difficulty in reporting symptoms objectively and interpreting them, and we as clinicians all have different views which colour the way in which we also take a history. We put that together. Of course, urodynamics is useful, but it can be chaotic if you don't know what you're doing, and all too often, probably about 70 to 80% of the urodynamic traces we get sent from peripheral and other hospitals in my country are complete rubbish because of the artifact and methodological problems associated with it. So you have to use the history, the interpretation of what's going on, and with discussion with the patient. And at the end of the day, urodynamics is a subjective interpretation of objective parameters by the investigator. Symptom scoring is an objective interpretation of subjective parameters, if you look at it that way around. The history is littered with various terms, but at the end of the day, detrusor overactivity is now the new term which is used to replace instability or hyperreflexia, and is idiopathic or neurogenic. And the overactive bladder, as you know, is a symptom complex, an empirical diagnosis with the caveats I've mentioned, and you have to exclude other pathology, exclude hematuria, exclude bladder stones, exclude cancer where you feel it's appropriate. At the end of the day, it's very common, and it affects men at least as commonly as women, but clearly incontinence is more common in women than men. Urgency is thought to be the cardinal symptom underlying it, and of course urgency is a sensory symptom. But if you get urgency, you go more often. If you go more often, you have a reduced voided volume. You may go more often because you've got urgency incontinence in a third of cases, and you may have nocturia, which is possibly related to overactivity, but don't forget the physiological causes. And you can't interpret nocturia unless you use a frequency volume chart in both men and women. If you don't use that, and it's coming out from all the international guidelines, you're not investigating patients appropriately. So that in the past we've tended to think upon women only as having this condition, this sensory disorder, if you like, and forget that it is also important in men, because the storage symptoms are the storage component of lower tract symptoms. And over the next year you'll see coming out of multiple publications emphasis on this from epidemiological work in both men and women, showing very clearly that the symptom complex of lower tract symptoms, which is not disease specific, contains these various components in both men and women, and hence the importance of adequate evaluation of patients. You've got to look down at the bladder, and you've got to look at it in a new light when you understand this background to it. The International Consultation on Incontinence held its last meeting in June of 2008, and we looked, for instance, at the antimuscarinics. There was a landmark study in the BMJ from the Cochrane collaboration in 2003, which caused a stir in the area of function, urology and urogynecology, because it suggested these drugs didn't work. But it didn't use modern studies, it didn't look at outcomes relevant to patients, it made comments on quality of life, none of the studies which used modern qualitative measures, and it lumped the drugs together. As you can see, I didn't like the paper. I carried out a meta-analysis which subsequently was reported and updated in the last year with a number of colleagues, where we looked at the world literature and updated the previous study. So you can see here that we had 88 plus a further 73 studies which were included. Another group in Italy carried out a similar analysis, and basically the consensus view is that all of these agents have withdrawals associated with them as compared to placebo, but some agents such as oxybutynin are less well tolerated than others. We know that. And if you look at adverse events, you can see the same. Quality of life is improved, but it's difficult to know how to interpret this based on scores relating to the clinical scenario. It's very clear, though, that these drugs do differ in the terms of the way in which they are delivered to the body, the pharmacokinetics, which we don't understand, their metabolites, and there are aspects of these drugs which are important in terms of side effects, particularly relating to tachycardia and other side effects. The recent developments in this area have been once-a-day drugs, which you see now for oxybutynin, for solifenacin, for tolterodine, for fesoterodine, and more recently for trospium, released in the States. These once-a-day formulations are now well tolerated, and it's also important to have dose flexibility with these agents. There is a number of antimuscarinics which are pure antimuscarinics, as you know. The most commonly used now are tolterodine, solifenacin, and trospium. Fesoterodine is a major metabolite of tolterodine, which has recently been introduced. Darafenacin has got subtype selectivity. It's got M3 over M2 selectivity, which is about 50-fold. M2 is effects on the cardiovascular system. It's got M3 over M1 of about 9-fold, which is marginal in pharmacological terms, although that's been augmented in terms of cognitive function. So I don't think there's good clinical evidence for that. If you look at the levels of evidence, certainly all the new agents have a level 1 evidence and grade A recommendations. Drugs with mixed action, don't forget oxybutynin's a potent local anesthetic. If you suck a tablet, you get a numb tongue. An interesting story there, they tried to introduce it with rectal administration a number of years ago, but it anesthesized the anal virgin, led to anal leakage. So it's interesting that aspects such as that may be important. Clopidogrel used to be the most commonly used drug in Japan. It's got a similar profile to oxybutynin. Again, level 1 evidence. If you ever use fluvoxate, Urispas don't. 2 placebo-controlled studies, the only 2, one worse than placebo, the other the same as placebo. It's commonly used by general surgeons in my country, and probably shouldn't be used because it doesn't work. Imipramine has been used, and certainly we all find that it may have useful sedative properties, particularly if patients have got nocturia, but don't forget it can be toxic in the elderly, and there's a lot of case reports now suggesting from the cardiovascular literature that it can lead to death if you've got underlying problems, so use it with caution. The evidence base is also old, not particularly good. Duloxetine was introduced for stress incontinence, but the evidence for overactive bladder incontinence is very weak. Vasopressin, DDAVP, has been used. It's an antidiuretic with no direct bladder effect and no cardiovascular actions. There's good evidence for nocturia, it may be useful, less good evidence for overactive bladder and storage symptoms. And in the elderly, over the age of 60, you've got to be a bit careful. I have to say elderly over 60 because it's elderly in terms of physiological mechanisms. You can get fluid retention, and so it's mandatory to check routine biochemistry within the first week, and probably about 3 weeks later, to check there's no hyponatremia due to water retention. There is evidence that you shouldn't use alpha blockers. There's a study now, level 1 study, showing it doesn't work in women, although there's been all this talk in recent past that alpha blockers may work on storage symptoms in women. It was a negative study. A grade D recommendation you shouldn't use. In fact. Beta-3 agonists are coming along, as I mentioned. Limited evidence at present. Phosphodiesterase inhibitors, there's good evidence from a number of studies in men. You improve storage symptoms, you don't improve flow rate, and certainly that may well be methodological in the way the studies were designed. But certainly that's now there. Although it isn't licensed for that use at present, that's being sought at present by a number of agents. There's limited evidence for COX inhibitors. The toxins I've already mentioned, level 2 evidence, because of the retention risk and so on, grade C recommendations for neurogenic bladder, and grade C also for rhinocerotoxin in idiopathic detrusor overactivity, and likewise botulinum toxin. We've now got regulatory studies being carried out, and one will be reported at the AUA this year, coming up, which we will see the data on. So, at this stage, I hope I can show you that there's a field change in the way we understand the mechanisms underlying bladder behavior. Central mechanisms are important, and peripheral mechanisms. The most useful target is probably going to be the peripheral mechanisms because of the toxicity of agents at present. Antimuscarinics are still the mainstay of overactive bladder treatment, and surgery now is becoming an increasingly uncommon procedure, the clam cystoplasty, which is why I didn't mention it, because we rarely use it now with the use of botulinum toxin and sacral neuromodulation in patients who fail to respond to drug therapy. There are multiple efferent and afferent pathways, and I would suggest to you that the emphasis now is on sensory pathways as future targets for pharmacological intervention. Thank you very much.